introduce the course. So, as I said, this course is to prepare you for your later clinical courses and to get you ready for the boards exam. And the boards, there will be neuro questions on it. For example, here's one. I took out of a board a few questions. I'm not sure you better answer these now, but by the end of the course, these will be so easy you won't even bother. Take you 2 seconds to answer these questions. These were taken from a board review exam book for PTs. Okay, let's have a go and see if we can figure out anything about this. This is an example. You might know some of this from your physical agents course. Okay, a lady has come into rehab hospital after sustaining a stroke. Okay. She identifies significant sensory deficits in her lateral spinothalamic tract. Which sensation will be most affected? So basically that means there are lots of pathways going up the cord, and each sensation has its own pathway in essence. Okay? And they go up different places of the cord. And we'll talk about in a minute. There's a big strong correlation between neuroanatomy and neurology. In other words, if I know my neuroanatomy, I know why these signs and symptoms are presenting. Okay, so this lady has these various deficits. Which of those deficits would be most likely affected if the patient has lost the lateral spinothalamic tract? PT should know this, right? Because you've had this, I think, in your physical agent. So I don't expect OTs to know it unless you've had a cook. What would it be? Temperature. Temperature is lost because we know pain and temperature go up the cord to the lateral spinothalamic tract. That tract goes from the spine to the thalamus. Obviously, if you've never heard of that tract, if you never had a course, you wouldn't know that, but that's a very simple question you get in a board exam. Now, these are examples of stuff we'll go over. And number 2, we're going to come to that in a minute. But basically, a patient has an incomplete SCI, spinal cord lesion, and she's got paralysis on the ipsilateral side. Do you want me on ipsilateral? Yes, you all know ipsilateral, right? Ipsilateral side. So she's got paralysis of whatever. Let's pretend it's an arm, leg, whatever. On the ipsilateral side of the lesion, same side of the lesion, she's got paralysis, and she has lost pain and temperature on the contralateral side of the lesion. That makes sense. So she has paralysis of the right leg, let's pretend, and she's lost sensation of pain and temperature on the left leg. What the heck has happened to her? Okay, so she has a syndrome. Which of those would describe the syndrome she's presenting with? A very classic sign of a unilateral spinal cord injury. And any guesses? D, Brown-Séquard syndrome. That's what she's got. Yeah, and we'll go over that in a minute. These are just examples again. Okay, 13-year-old male got CP. Slow, involuntary, continuous writhing movements this patient is presenting with. So it'll be sort of like this. The patient will be doing this kind of thing. And basically, what is that known as? Is it ataxia? What's ataxia? A, without taxine organization, right? Ataxia is uncoordinated movements. Does she have that? No. Does she have spasticity? No. Does she have hypotonia, less muscle tone than normal? No. She has apoptosis, or he has it. He has apoptosis. That is the name of when you do this kind of thing with a hand. That's apoptosis. And we'll go over later why a patient gets this. I'll show you a video of apoptosis, where in the brain a person has a damage that will cause that. So again, these are just things we're going to learn by way of induction in this course. What have we got here? Dysmetria. Dysmetria is a very, very common sign. What's the difference between a sign and a symptom? The patient presents with these signs and symptoms. What the heck is a difference between a sign and a symptom?
You can see a sign and they tell you the symptom.
Exactly, yeah. A symptom is a subjective report by the patient. I feel numb in this leg. I feel tingling in my left hand. A sign is I have the patient do something, I see something. I have them do a Romberg test, they fall over, they limp, I see something. That's the sign. I provoke a sign in the patient. A symptom is something she or he tells me they have. I can't actually see it. But they're used interchangeably, unfortunately. I mean, I'll do the same. I'll say symptoms meaning everything, but there is a clear, definite distinction between a sign and a symptom. Okay, she's got these signs of dysmetria. Very common with cerebellar dysfunction. What is dysmetria? What wouldn't she be able to do there? Marching in place, walking at various speeds, placing her feet on markers while walking, and rapid alternating pronation, supination of the forearm. So this is a classic one you'll ask the patient to do. Can you do this for me, please? And if they can't, that's called dysdiadochokinesia. So that's not that. We'll come to that later when we look up cerebellum. It's answer. Take a guess. She'll also have a problem doing this, right? When you get pulled over by the police and you try having to do this, she'll do this. Or you ask a patient to touch the end of your finger, you hold your finger out like that, say, touch the tip of my finger please, and she'll go like this. Like that. She has dysmetria. Okay, which of those then do you think would be most B. Placing a feet on floor, feet on the floor marker. That would be dysmetria. Sometimes called past pointing. You can't hit a target with a limb. You miss it. Last one for you. What's this one? Signs of autonomic nervous system dysfunction. Okay? So you know the autonomic nervous system, flight and fight versus what's the other one? Sympathetic is flight or fight. Parasympathetic is what? Rest and digest. Okay? So this is asking, which of the following is not an indicator of increased sympathetic involvement? So which of these things, if this patient has too much sympathetic outflow going on for one reason or another, we'll talk about reasons why she can have that. Which of these would you not see? Not see. So which of these things would you not see? In other words, which of these would you see with sympathetic involvement? Flight or fight response, you're going to get these things happening. Which of these would not happen with increased flight and fight response? C. Constriction of pupils. When you're scared, you're taking a hard exam, your pupils will dilate. Okay? You'll also be anxious. You also have cold, mottled, shiny skin. You'll also have rapid shallow breathing. All those are symptoms of sympathetic increase, except for C. Constriction of the pupils. What nerve does that cause? What nerve constricts the pupil? What nerve is responsible for constricting the pupil? Optic nerve, right? No. Good guess. Optic nerve is responsible for sight. Okay? Vision. What nerve, what cranial nerve shuts down or is responsible for moving the pupil? Oculomotor. The oculomotor, cranial nerve 3 is out. And we'll come to this again, but I thought maybe some of you might have known that. Oh, some of you did, of course. Alright, a couple more, then we'll start talking about, let's just give here's a complicated one for you. Alright, you won't get this on a boards question, you might get half of this, you might get one paragraph. But this is the sort of thing you'll get in a clinic. Okay? Let's just go through this. This is I know you're not going to know all this, but this is, by the end of the year, this is the stuff you will know. Okay? So, a 73-year-old man comes to history of mild headaches and somnolence. What does that mean? Somnolence, for example. You should know, you've had a medical terminology class, right? What is that? When he has mild headaches and somnolence, what's that? Any idea? He has a hard time sleeping. Okay, he has a hard time sleeping. You're going to diagnose this patient for me, right? His wife notes periods when he seems off. He's been napping frequently. He has poor appetite. No history of trauma, seizures or focal neurological deficits. systematic blah blah, cardiopulmonary gastroenteritis looks fine. That's not a problem. He drinks 5 ounces of hard liquor a day. Okay. But he does not smoke or use drugs. He's travelled recently and there's been no change in his daily routine. He takes aspirin. Nothing there. What's happening? Okay, so he's got a headache. That's the only thing we really got here, and he feels off sometimes. He appears well, slightly vague. Glasgow coma score is 15. Anybody have heard of the Glasgow coma score? No? Yeah? So it's basically if a patient has been transported to the ER in ambulance, the ER docs want to know his Glasgow coma score. It's based on his verbal response, his response to pain, etc., etc. We'll get to that, but that's a good score. He's fine. His Glasgow coma score is fine. If it was 5, he's in a mess. It's highly predictive of functional recovery. Glasgow coma score, if you've got a bad one at the beginning of the injury, his likelihood of having full recovery is pretty poor. So it's correlated with their functional recovery. Okay, blood pressure is 180 over 90. Okay or not? What's that? Bit high? Particularly is diastolic, but not major cause of concern at the moment. His heart rate 80 beats per minute. Okay or not? Yeah, I mean, likely to be lower, but it's not crazy. It's not tachycardia, is it? 16 breaths a minute. Fine, nearly. Afebrile means he's got no fever. Okay, I was trying to figure out what's up with this bloke, right? Heart sounds are normal. Okay, and he's evolemic. What does that mean? Normal blood volume. He's got normal blood volume. Lungs are clear on auscultation. You haven't done that yet, have you? In your cardiopulmonary class, you will learn to do this. You will auscultate, you'll get stethoscope, and you'll listen to each other's lung sounds. See if you hear crackles and things like this. Signs of atelectasis and things going in the lungs. You'll go over lung sounds in your later courses. Here is fine. Abdomen soft, tender, no masses. What's a fundoscopy? It's normal. What is that? Again, all this stuff you'll see in your clip. You'll get these terms thrown at you. What does that mean? It's normal. So okay, but what would it be if it was abnormal? What is it? What's that test? So when a doctor looks in your eye, okay, gets one of those doohickey lights and shines it and looks at your retina to see if there's any signs of optic neuritis or the disc has been pushed in due to cerebral herniation or whatever. We'll talk about all this stuff. So all this will be common knowledge or simple to you at the end of the course. He lacks any pronated drift. What that is. Pronated drift, you have a patient hold their hands like this and the arm starts to do this. Gradually pronates. Involuntarily. Sign of brain damage. Negative Romberg sign. What does that mean? Have you done the Romberg test yet in any course? Romberg? No? Oh, I thought you probably would have. That's a very common one. Romberg's test, basically, you stand still, your feet together. Simple as that. Then you close your eyes, you do sharpen Romberg, where you put one foot in the other. Basically, test of balance. Can they stand up, basically, without swaying? So his balance is okay. It's a very simple test, but it's okay. Motor examination for all limbs, fine. Hyperreflexic, what does that mean? What's hyperreflexia? Pretty obvious, really. It's what it means. That's what it means. What is it? It's exaggerated reflexes. Exaggerated reflexes. Okay, then let's quickly go through this. Mental status, complete blood count, chest x-ray, blah blah blah, or urinalysis, all normal. Sodium slightly elevated, CT scan is performed. So now we're getting into this interesting stuff. Okay, this is his CT scan. What's wrong with him? What do you see wrong on that? You'll get, I know the PTs will get in your 6th year, I think it is, you get a medical imaging course. So you'll learn to read x-rays and CT scans and MRIs and that stuff. But basically you can see something wrong with that, can't you? What's wrong with that? It's a transverse cut to the bloke's brain.
Looks like the right side is deteriorating.
Right side is deteriorating. What do you mean by deteriorating?
So it's smaller than left side, and there's black all over it.
There's black. You mean this to here?
Yeah.
That's his left side.
Oh, I'm sorry. Right side.
So you're saying his left side is wrong. There's something weird going on here, right?
Yeah.
Is it? It's the opposite of that. What is this thing here? The ventricles, right? On his left-hand side, the ventricles don't look normal, but he's got them there. Where are they on the right-hand side?
Gone.
They're gone. They've disappeared. His ventricles have disappeared, have been closed down. Okay? So something's up there. We'll start. And you can see here signs of intracranial pressure, effacement of the right-sided ventricles. Effacement of the right-sided ventricles. They're gone. Disappearance. Okay? And you might get to see these X-rays. Midline shift is apparent. The brain parenchyma left side is atrophic, the prominent sulci. The right side lesion is hypodenic. Okay, basically, this you can see is messed up here. Its ventricles have gone. Something's happened here. Okay, so with those signs and symptoms, etc., etc., that X-ray, there's your answer. What's your diagnosis of this patient? I know I'm not expecting to know this now, but this is the sort of thing you will know. Sort of an intro to get you aware of what we're going to be doing. Epidural hematoma. Are you familiar what that is? An epidural hematoma? Upon the dura. So it's a bleed between the dura mater and the cranium. Do you know what the dura mater is? Yes? No? So there's meninges around the brain. Subdural hematoma, that's beneath the dura. Beneath the dura. Subacute chronic subdural hematoma, intracranial nerve, blah blah blah, subarachnoid hemorrhage. I'll tell you what it is. It's C. It's a chronic subdural hematoma. If it was epidural hematoma, you would see this white increased here. You'd see the brain pushed in this way, away from the side of the brain, from the bone. You'll see a white area here. So it's a subdural hematoma. And that would explain all this mess. This is a harder one. Do you want to quickly go through this one? The answers are there, and by the end of in a couple of weeks you'll know the answer to that one. You'll know which one of those it is. And okay, so very quickly we'll get some else. History of pain around his right ear, extending his temple, dizziness, discomfort in his throat, right arm not moved, normal manner, etc., etc. Key things here is neurological symptoms. Any words in there you don't understand? Blood pressure was a little bit low, no big deal. Heart sounds fine. No atrial groups. What's this here? Where's my thing gone? This thingamajig here. Here. What's this? What's going on there? There's nothing, but what would it be? That's a sound. You've got turbulence. Sounds coming from the blood flow in his neck. In other words, is there atherosclerosis going on in those arteries supplying the brain? No. Right-sided ptosis. What is that? So we've got this issue here. This is the key to diagnosing what's going on. One of the things here. He's got right-sided ptosis and meiosis. What is that? What's ptosis of a person's right side? I thought you might have heard this one before now. His eyelid is drooping. He's got heavy eyelid on one side, a drooping eyelid on one side. Okay? Meiosis. Any idea? His pupil is pinpoint and fixed, unreactive to light. Very, very small pupil. We've got some nystagmus. Increased sensation pinprick. We'll go through this later on, but no vacancy signs. What What's Babinski sign? See that one? You stroke along the bottom of the foot and you look at the toes, okay? It should curl. If it's abnormal, it'll dorsal blend. Anyway, we go through these, but I'm just saying, we can come back to this in a couple of weeks' time and all this will make sense. I know most of it probably doesn't make any sense at the moment, but this is a CT scan, and you see a problem here on his brain stem. Takes the skill to see that, but basically he has this Wallenberg syndrome. And we'll go over that and talk about his brain stem. We'll go over in detail what a Wallenberg syndrome is, why it occurs, where it occurs. And that's what we've got. Okay. That is just some of the stuff which will be common knowledge to you at the end of this course. Hopefully. That's our goal. Shoot. You see something like that, you go, oh, piece of cake. I know all those words mean. I know what they all are going to indicate what's happened to this patient. Here is the problem. Okay? I know obviously we don't know all that stuff at the moment, but at the end of the course, all those signs and symptoms, those syndromes will be pretty common knowledge to you. What's a syndrome? Wallenberg syndrome. What is that? What's a syndrome? What do you mean by this patient presents with this syndrome? What is that all about?
A collection of symptoms?
Yeah, a collection of signs and symptoms. A whole constellation of these problems with the patient is a syndrome. And for example, these are some of that is emblematic of a Wallenberg syndrome, etc., etc. Okay? So what we're going to start off today is talking about, I think it's whatever, on here, chapter something or other. I think it's chapter 4. Until I read this book often. Yes, chapter 4. The relationship between neuroanatomy and neurology. That's what we're going to start off with. So basically that chapter says that if you know your neuroanatomy, you know your neurology. In other words, you must know, to be able to assess and treat a patient correctly, the neurology of a patient, you need to know your neuroanatomy first. Okay? You need to know why these signs and symptoms present. A patient comes in with signs and symptoms, like we've just been talking about. Where is the lesion? What is the lesion? What type of lesion is it? What is it? If you don't know that, where the lesion is, your treatment could be off. Okay? Is this patient got CP or has they got MS? The way you treat that patient will be very different. If the patient has a Brown-acquired lesion versus a blah-blah lesion, the way you assess and treat those patients and the effectiveness of your treatment will depend on your accurate diagnosis of that patient's lesion. Okay? And the only way you can come up with that is to know your neuroanatomy first. Okay? You need to know where the lesion is. What's a lesion? What's the definition of a lesion? You're not talking about anatomy? What's a lesion? I just stuck a pin in my thumb. Is that a lesion? I just fell over, someone kicked me playing football, soccer, and I bruised my thigh. Is that a lesion? Somebody stabbed me. Is that a lesion? Yeah, it is. Yeah. That's a lesion. Lesion comes from Latin ledere, meaning to harm or hurt. So it's anything. Any site. People think lesion has to be a cut or something like that. A lesion is any area that's been harmed. Whether it be a knife wound, a gunshot, a bruise, a pinprick, a stroke, whatever. That's a lesion. It's an area of abnormality caused by harmful, something's a problem here. And there's a very strong correlation between the site and the type of lesion and the signs and symptoms you're going to see in the patient. So we need to know what's what in the nervous system. Okay, I'll give you a sign or symptom, whatever. A patient has aphasia. Alright? Where's the lesion? what artery would the lesion be in? Simple as that. The patient comes in with aphasia, you should know where the artery, why this patient, where in the brain is damaged, right? So what's aphasia? You've all heard that term, yes? Or no? That's not a common, not whatever. Aphasia. No? You must have heard that term, yes?
Something with speech and
Language, yes. The patient has inability either to produce or hear this language, or write. There's tons of types of aphasia. It's not a catch-all term. You can have verbal, expressive aphasia, semantic aphasia, receptive aphasia, blah, 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 blah. There's lots and lots and lots of those. And I'm sure in OT you'll go over way more than we were in PT, but there's a few types of aphasia we'll go over later on. The aphasia is problem with language for now. Simple as that. Let's say patient can't speak, she has motor aphasia, she has problems producing language. Where, and I'm going to tell you, we have a lesion in a specific artery, a big artery. What would it be? Where would it be? Aphasia. The ability to produce language is in what part of the brain? I think you should know this. I hope, but maybe you don't. The lobes of the brain, right? You know the hemispheres, left, right, yes? You know all lobes? Do you know the lobes of the brain? Yes. Of course you do. Frontal, parietal, occipital, temporal, yes? The incident, so you know that. Alright. So where is language produced? Most things, right? Most functions of the brain are bilateral. There's a bit over here and a bit over here. But within language, this is one of those things you only find typically, not always, on one side of the brain only. The speech center, what are you going to call it, is called Broca's area. Is that a term? Anything heard Broca's area? Broca's area is the area that's responsible for the production of speech. Okay? And this is only found on one part of the brain, one specific area. Some people actually have it on two areas, and they find that's often correlated with stuttering. They find a bit on the left, bit on the right, but usually this is only on one side of the brain on most of us. And which side is it on? Left. The left side of the brain. Well done. Yeah, the left side of the brain produces speech. And you know where on the left side of the brain it is? I shall draw the brain for you. No, that's not the brain. It's more a frontal lobe. That's a brilliant diagram of the brain, right? This is the spinal cord, right? This is the brain stem. What's this thing hanging down the back? Cerebellum. Okay, so it's not to scale, of course. Frontal lobe, temporal lobe, occipital lobe, lateral fissure. Where is that Broca's area? This side is the right or left-hand side of the brain? What side of the brain have I drawn?
The right side.
The right. Okay? There we go. I should have drawn the other side because Broca's area is on the left-hand side of the brain. And it's right here. On the frontal lobe. On the left-hand side. Just above the lateral fissure. Okay? That's where Broca's area is. That's what causes aphasia. So, my question now then, hopefully some of you might know this, what artery supplies that area of the brain? Still, if you don't know this, we're going to go through this, but I'm just trying to show you how the knowledge of signs and symptoms correlates with neurology. And it is the middle cerebral artery. The middle cerebral artery supplies that part of the brain. Have you heard of the artery, the middle cerebral artery stroke? So that artery roughly supplies this chunk of the brain there. Roughly. That's the middle cerebral artery, very important artery. So this patient has had a stroke in the left middle cerebral artery, and he or she is presenting with aphasia. Simple as that. You know a patient got aphasia, this is what's going to be the issue. Okay? In 99% of the time. Okay? This is what's known as it would be called a focal injury or focal lesion. It's in one place only. It's in this artery. Okay? So a stroke is a focal lesion. A spinal cord injury is a focal lesion. Okay? As opposed to a multifocal lesion. What's a multifocal lesion? And each of these types of lesion will give you different symptoms, signs, symptoms. What's a multifocal lesion? Well, give me an example of a multifocal. Many sites. The most common one in the central nervous system would be what? TIA, transient ischemic attack. That's more like a focal lesion. Usually one place, one artery's vasospasm, something like that. Okay, I'll give you a clue. A patient comes in and she presents with tingling in her hands, weakness of the legs, and blurred vision. MS. Multiple sclerosis, multiple scars. It's a multifocal problem. And there are different places of the brain and the central nervous system have lesions in it. You cannot explain that besides with any other lesion apart from a multifocal lesion, and that normally would be MS. That in fact is the key to diagnosis of MS. A weird signs and symptoms, a different whole collection of signs and symptoms that are not correlated at all for some reason. Why would you think tingling the fingers has got anything to do with your left eye being blurry? What is the structure that connects my little finger and my eye and weakness in my quads? There's nothing. Except the nervous system, obviously. And it's not one pathway. It's multiple pathways. Multiple lesions and multiple sclerosis. So when a patient comes in with weird signs and symptoms, you can't, how on earth have you got this and that and this and that? That is the easiest way to diagnose MS. There's nothing else to explain that weird mess of signs and symptoms the patient will have MS. So again, it is correlate between function and structure. You might get another way, some lesions are called diffuse. A diffuse injury. In other words, there's not one focus, there's not a multi-focus, but there's lots and lots of systemic issues. For example, diabetes. Diabetes is a systemic, diffuse issue affecting the whole body. Nervous system. Okay, so again, we're trying to show there's this correlation between structure and function. Let me give you an example from anatomy maybe. And just like anatomy, where we learn to figure out the diagnosis by like an investigation of the signs and symptoms and tests. Okay, a patient can't do this. A patient cannot oppose their thumb, let's say. So we're going to work our way through the whole system, figuring out where is the lesion, why can't the patient do that? Simple as that. And you'll see there's a correlation between the structure and the function. So the first reason it could be is the opponent's pulsus muscle is damaged for some reason. So that's the most peripheral problem it could be. Okay? It's not that. What's the next thing it could be? As we work our way up the system. Why can't I oppose my thumb? What nerve is that? Median. The recurrent branch of the median. Very good. So where is the most distal site of a lesion that could prevent my thumb from doing that? Carpal tunnel syndrome. Okay? The median nerve could be trapped in the carpal tunnel syndrome. So again, correlation between structure and function. Okay, how would I know that it's... How can I test for carpal tunnel syndrome? Tinel's test, right? Simple. Or various other tests. But It is not in the carpal tunnel, I know now. Where next up the chain could it be? Pronator teres, right? Pronator teres syndrome. It could have been entrapped in the pronator teres. In that case, if it was in pronator teres, what else would you find a problem besides thumb movement? Various things, wrist, finger flexion, things like pronation. The median nerve after it supplies pronator teres could be needed. Okay, myocardial syndrome, whatever. Okay, no, it's not there. Where else? What's the next thing up? Here sometimes. Some people have a ligament here. Ligament strut. Okay, not that. Up here. What's next? What's up in here? It could be a problem. Thoracic outlet, right? Brachial plexus issues. Okay? Could be various places in the brachial plexus due to thoracic outlets impinging the median nerve. It's not that. Where do we go next? Nerve roots. What nerve root would this be? 8. C8. We could look at C8. It could be a osteophyte growth on a nerve root in intervertebral foramen. It's not that. So where do we go now? All that's fine. Now into the nervous system, or central nervous system anyway. Okay? Which part of the brain controls my right hand? Left hemisphere, right? And what part of the left hemisphere controls it? What part of my left hemisphere, where would I have to stick a pin in, whatever, in my head, in my hemisphere, my left hemisphere, would I say that part of the brain there sends signals to my right thumb? Where would it be? Any idea? It's in the motor cortex, right? The motor cortex. Where is the motor cortex? Where is my motor cortex? It is. There's a crack in your brain here, right, between two lobes. What's that crack called? Central sulcus, right? Heard that term? Is this news to you? Central sulcus?
I just need to remember it.
Okay, well you had it, right? So
Yeah.
it's coming back to you, right? Central sulcus. This lobe is the frontal lobe. This lobe is the parietal lobe, or parietal lobe now. Where is my motor cortex?
It's right in front of the frontal lobe.
It's right here. On the frontal lobe, the strip of the brain called the motor cortex that controls the other side of the body. And this would be the right hand side. This is my left. Obviously, this would be on my left hand because I've been drawing the right side of the brain here. Any idea whereabouts on that motor cortex the hand is controlled? It's somatotopically organized. In other words, it's body mapped. It's not random. It's a specific place. Every part of the body has a specific place on that motor cortex where the brain, where it starts, and where the nerve starts. And it's about here. Right there. So halfway, probably even lower down, probably more like here, somewhere about there. And again, it's supplied by the middle cerebral artery. Okay? So, again, I can go through the whole system and figure out where the lesion is if I know my neuroanatomy. Give you one more example. What time am I supposed to stop? 10? Wow. I said nothing yet. Alright, let's do another one. I can't extend my, I don't know, let's say my left quad. I've got a problem with my left leg. I can't extend my left knee. Alright, why not? What's the most distal thing? Could be a quads of bruised, of damaged, whatever. Could be a muscle problem. It's not a muscle problem. What else? Okay, here's my brain. Here is my spinal, here's my brain stem. Here's my spinal cord. Here's my quads. Okay, here's his left, his right. Those are his hands. Right. We've got a very big brain stem, but let's make him a bigger brain. Alright, somewhere in here, brain stem, spinal cord, legs, arms, whatever. This bloke cannot extend his knee. It's not his quads. Alright? So, something in the nervous system. Let's try and figure out where this problem is by assessing this signs and symptoms of this bloke. Okay, so we do. What's the next thing going into the system? If it's not the quads, what could it be? What nerve supplies the quads? Femoral nerve, right? The femoral nerve comes out the cord and goes to his quad. Okay? How would I test that that's in... So which side of the brain could it be? If it's this, it's his left quads, his left leg is a problem.
It's the right hemisphere.
His right motor cortex would be a problem. There's his motor cortex, and with his legs are in here somewhere. Near the center. Near the long ventral fissure. Okay, so we know it could be a stroke. In this case, it would be the right anterior cerebral artery, not middle cerebral artery, because this area of the brain is supplied by the middle, this area of the brain is supplied by the central, and we'll get to this later, obviously. Sorry, not central, the anterior cerebral artery. The anterior cerebral artery supplies the sort of center portion, middle cerebral artery on the outside. Alright. So it could be there, it could be down here. It could be femoral nerve, right? How can you test the femoral nerves working? If he has no voluntary control over it, let's pretend, how can I test his femoral nerves intact? Simple. Come on, you know it. Reflex, you whack the heck out of his patella tendon, right? You whack his patella tendon with a really great big hammer, and what would you expect to see? His knee extends, right? He's doing the reflexes, right? You whack his patella tendon, his knee extends. What have I just done by doing that? How does a patella tendon shoot? Why does me hitting a person's patella tendon cause the quadriceps muscle to contract? Why?
Because it's the reflex arch and it's in the spinal cord.
Yeah, the reflex arc, right? So, there are little receptors in the muscle, in the quads, called what? They detect stretch. Come on. It's nothing to do with the tendon, is it? You whack the tendon, when I whack the patella tendon, it pulls on the quadriceps muscle. Touch, a slight touch. There are muscle spindles in the quads, which detect change in length. They signal the spinal cord via the dorsal root, via the femoral nerve, the sensitive portion of the femoral nerve, into the cord to cause contraction of the muscle through the alpha motor neurons. So if your patella tendon tap reflex works, it means your femoral nerve is fine. So the patient's inability to voluntarily move their quads, the knee extension, is not due to a problem with the femoral nerve. We just tested that. It's intact because the reflex works. Alright. I'll give you some more signs and symptoms. You tell me where the lesion is. His right quadriceps is fine. Alright? His right quadriceps is fine. He can move that voluntarily. You then start thinking, well, let's test his sensation from his right quads. I stick a pin in the bloke's thigh. Okay? I stick a pin in the bloke's thigh. And he goes, ow, that hurts. Okay? I stick a pin in the bloke's right thigh. He goes, big deal. I'm tough. It hurt me. So I stuck a pin in his right thigh and he didn't feel it. How is that possible?
The sensory root and the spinal nerve?
The sensory root of the spinal nerve. Not quite.
I don't know.
I get a Bunsen burner and I burn his bloke's leg, his right leg. Yeah, big deal, nothing. That's no big deal to me. Can't feel that. I then burn his right, you get obviously a test tube with warm water and whatever, but let's pretend we've got a Bunsen burner. And we flame through his left thigh and it hurts. Lo and behold. But his right did not hurt. His right leg didn't hurt when you put a Bunsen burner on him. Okay? You then test his proprioception for his left leg. Proprioception, his left thigh, his left knee. Does he know where his knee is in space with his eyes closed? Does he know what his leg is doing? Does he know his ankle is? Whatever, pretend it's a knee. Does he have proprioceptive feel of his left knee? He doesn't. He has no idea what his left knee is doing. His right knee, yeah, that's fine. We go up to his arms. You stick a pin in his left arm, he feels it. You stick a pin in his right arm, he feels it. You do proprioception in his right arm and left arm. Fine. You look at his motor supply, can he extend his elbow? Flex his elbow on both sides. Fine. Okay? So, where is the lesion? Is it in his right cortex here? Has he got a stroke in his right cortex? Would that explain the lesion? He can feel pain in his right hand side and his left leg, right? Where's that sent? Where do you feel pain in your left leg? What part of the brain? Right hemisphere or left hemisphere? Right. I feel it in his right hemisphere. So, it can't be his right hemisphere, right? It can't be. Let's pretend his motor symptoms, if his motor symptoms, if you only look at his motor symptoms and he can't move his left leg, it could be right hemisphere stroke. But the fact is, he can feel pain from his right leg, his left leg. How is that possible then? It's not a stroke in his right hemisphere, therefore. It must be somewhere else. How can you explain that if you don't know your neuroanatomy? Can anybody explain those symptoms for me? That's because you don't know your neuroanatomy. Well, I don't expect you, but this bum, 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 bum. It's that deep. It's a Brown-Sequard syndrome. That's what his patient's got. Because, this is why. How do I get, where does the motor pathways go from the brain to my left leg? The neuron starts up here, right? It comes down through the brain. Where does it cross to get to the left-hand side? So you know it starts on the right, it gets to the left leg. How does it get there? Where does it cross to the other side of the nervous system? My motor pathways. Most of them. Any idea? In the brainstem, the bottom of the brainstem. They come down here, they cross the other side there. Then they go down contralaterally down the cord. Okay? So there's the brainstem. These come down and do this. And they synapse, of course, in the ventral grey horn, and my motor neurons come out to my quads. Alright. How does pain and temperature get from the left leg to the right brain? They cross, obviously, don't they? Where do they cross? Where do they cross to get to the other side of the central nervous system? They cross at the segmental level. So in other words, pain sensations to this thigh comes in and does this. put the pathways in, but that's the route it takes. Okay? You know, I prefer that synapses here, but whatever. We go like that, essentially. We have got the balance, but there's another synapses there, whatever. So that's the pathway. So pain and temperature travel contralaterally up the cord from where they came in. That is, okay, so that is why, think about it now. Could he feel his left leg? Yes. Could he feel his right leg? No. Last thing, proprioception, and we'll stop. Where does proprioception get to? How does proprioception get from the left leg to the right brain? Where does that cross over? It comes in, obviously, from the left leg, and it goes up ipsilateral to the brainstem, where it crosses over. And does that. So that's proprioception. Black is motor supply coming down, green is proprioception going up, pain temperature is red going up. This is going up. This is going up, and the black is coming down. That's the motor supply. Okay, so where's the lesion? L3, L4. Somewhere between L3 and L4. L3 and L4, your nerve root's going to your quads, right? Where it could be there, it's in the spinal cord, right, isn't it? Because if it was up here, you'd have a different pattern of signs and symptoms. The lesion is between what nerve root and what nerve root. What level of the cord could it theoretically be between? Could it be at C7? Could I do a nerve root cut here, a spinal cord cut at C7? Would I find the same pattern of symptoms? No, why not? Ready? His arm. Yeah, his arms are fine. His arms are fine. So we know it's below what level? Brachial plexus is at what level? T1. So somewhere below T1 and above L3, L4. I mean, L3, L4 is the nerve roots coming out. So it can't be L5 because we've got 3-4 issue with the quads, right? Which side of the cord is it cut? Is it complete cut through the cord? No, because obviously there's stuff getting up there. So what this patient has is a ground sequoid lesion, and they have a cut somewhere, a hemisection of the cord like that, somewhere. So anywhere between T2 and L5, roughly, we have a slice to the bloke who had a spinal cord injury. It's affected half of his cord. And in this case, it's left cord. Does that make sense? Motor supply to the left leg. Right leg, where does it come from? Motor supply. Right leg, left brain. Fine. Pain and temperature from the left leg. Fine. Proprioception from the left leg. Not okay. Motor to the left leg. Not okay. Pain and temperature from his right leg. Where's that going? Comes across here, goes up here, and can't get through. So that's why he can't feel somebody burning his right leg. Does that make any sense at all? So this is why you need to know this mess to be able to know why these patients present these signs and symptoms. Simple as that. Correlation between neurology and neurotomy. And that's what all this course is about. Alright, we're done.